Okay, great. So hopefully everybody got what I was going over in regards to the Omicron variant and vaccine effectiveness, which is the title of this presentation. So, all right, what we see here that's being modeled on the left is actually SARS-CoV-2 in its sort of generic form. And those little red spikes that we see on the top are the spike protein, which is often what the vaccines are derived to help us combat against. Our immune system is one of the first things it tries to develop antibodies towards. And what we see here on the right is just that spike protein, and it's kind of drilling down on what these mutations are, which is really what makes Omicron so much different than the other variants. And actually, it's kind of almost corresponding to what makes them difficult to treat, sometimes what leads to them being immune evasive. We'll go into that in a bit, but also what can lead to it being more virulent, less virulent. A lot of it deals with the spike protein and how it infects our cells. So that's kind of what you see here in the beginning. And I will let Ayan take it over from here.
Perfect.
All right.
Okay, so before we go into variants, I do want to give a brief summary on how the viruses even attack our body, just so we have a better understanding of where the variants come from. So typically, viruses will attack our healthy cells and go inside the cell and make copies of itself. So specific to COVID, it enters through our nose or our mouth when we inhale air that has been contaminated by droplets containing the virus. So in the previous slide, you did see the spike proteins that are on the virus. That will go into, well, the whole virus goes into our lungs, but that spike protein is what latches on to our cell surface. And it actually latches on to receptors called ACE2. So once it does that, it triggers the binding. The virus goes into the cell and then it makes copies of itself. Then once that cell is infected, the cell releases the virus and then continues attacking other healthy cells. And then,
All right, next slide.
Next slide, yeah.
Right.
Or actually, do you want to talk about the mutations from that slide or?
So what she was trying to briefly kind of cover here is the coronavirus enters our cells through the ACE2 receptor, which is often fairly prevalent in our nasal pharynx area, but also in our lungs. That's why people get often a cough, a dry cough frequently, and it leads to shortness of breath and hypoxia. We have really low oxygen levels. The thing is, once it enters our lung cells or the cells that contain the ACE2 receptor, it tends to go into replicate. And then with viral replication, when a virus replicates, it's kind of sloppy at it. It doesn't do it the same way each time. And so when it's able to get into a viable, unvaccinated body, it can replicate in itself and make even more copies. That's how these variants develop. So that's why you often will see these variants, as we'll go into the next slide, they, of course, started in India, where there was very poor vaccination rates. You had some that came out of South Africa, Brazil, where they had low vaccination rates compared to where we were in other parts of the world, where they were able to get the vaccine first. So there's a whole other thing we could do on vaccine equity, but that's what led to some of these variants going forward. And you can see here with viral replication, with the variants, once it changes from the original virus, such as the Wuhan in this case, it can still infect our cells, but our cells may not be ready for it. And so what we then have when we have too many mutations that keep occurring during this replication cycle, you get something like all these different types of variants we have right now. And so as we can see here at the top, we have alpha on the left, beta, and down here on the lower left is the Omicron variant, or the B11529. I know this seems like a lot of science for folks, but the biggest thing to take away is the virus infects you, it replicates poorly, it makes mistakes, and then those mistakes often show up on the spike protein, and thus it makes it harder for our body to recognize it, say when we're exposed again, such as a new variant. All right, take on Ayan.
All right, so I did want to mention before, according to the World Health Organization, a virus that has one or more mutations is considered a variant. So like Dr. Ferguson said. So initially we had the Wuhan strain that, flipped all of our lives upside down. And that started back in December of 2019. But by January, end of January 2020, that's when the World Health Organization declared a public health emergency. So that, I think, yeah, that strain is obviously the one that had the highest mortality rate. And it was typically people who were older, people with comorbidities like cancer, kidney disease, diabetes, and people with autoimmune issues. They were at high risk. And the 0.4% is mostly people who were healthier. And as of January 10th of this year, more than 5.5 million deaths have been reported. And then late November, sorry, should I let these people in? Okay.
Lori and them will handle that.
Okay. So late in November, UK first discovered the first strain, the variant, I'm sorry, and it was the alpha. And then we had beta and also the gamma, which was in South Africa and Brazil. So the alpha became a variant of concern because it was spreading even quicker. There was about a 40 to 80% more transmission rate than the original virus. The mortality rate ranges from 0.9% to 4.1%. And then lastly, we have Delta. It was discovered in India in late 2020, and it still is more deadlier for younger demographics. Mortality rate is it's about 0.8% to 2.9%. So
the biggest things, and thank you, Anna, that was great. Big take home points here is mutations occurred. We have different variants. Overall, we've had over 5 million deaths, and the number keeps rising from SARS-CoV-2 since it broke out in December 2019 in China. The reason we see a mortality range changing, we now have vaccines that are affecting the mortality, how deadly the SARS-CoV and its multiple variants are to us. We have people with prior infection, so our body has now been taught what SARS-CoV-2 is, so it knows how to combat it. So that brings it all down slightly. And also remember, the virus keeps making mistakes as it produces variants. So, and for a virus to survive, it can't keep trying to do its best to kill off the host, or else it won't be able to spread to the next cell. So that's why I think we have now seen this one offshoot of Omicron. I can't predict on if we won't have deadlier ones in the future, but as it continues to be more transmissible, we have more and more people that have been infected with COVID, and we have more and more people that have received the vaccine. That mortality rate will continue probably to decrease because of what I just mentioned. All right, very good, Ayan. And so would you care to start off here?
yes, for sure. So currently we are dealing with the Omicron variant. That is the current variant of concern. It was detected in Botswana and South Africa, November of 2021. It's been reported to be about 3 to 6 times as infectious as previous variants. However, it's not as effective, so it's not as severe. Studies have shown that Omicron has a high transmission rate, and increased immune evasiveness, so meaning it is, what is the right way to explain it? Increased immune evasiveness, so it is attacking us. There are breakthrough cases, even though we are vaccinated, because this variant is different from the previous ones. So, but the vaccine is still protecting us from hospitalization and death.
I think the bigger thing that explains the evasiveness is it's kind of like if someone is trying to avoid you. It's very good at avoiding our immune fighting cells, particularly antibodies that are there, because they're finding it really hard to stick onto it. So thus it has more time to get into the cell and then replicate. So very good, very good. Next.
Okay.
So what are these vaccines to help us out?
Yes. So we'll go over the three main vaccines, the Pfizer, Moderna, and Janssen. So currently, Pfizer, Moderna, there's 2 doses. As we all know, Pfizer, you get the first dose, and then 21 days after, you get your second dose. So now children 5 and up are eligible for it. And boosters are available for individuals age 12 and up. But you get the booster shot 5 months after your primary series, so the first 2 doses. And then same with Moderna, 2 doses, except it's 28 days apart. Ages 18 and up are eligible. And for the booster, it's also 5 months. So scratch the 6 months, so 5 months after your primary series, and for individuals over 18. And then with the Janssen, it is the 1 dose for people 18 and over. Boosters are available 2 months after your initial dose.
Very good.
All right, I'll have you explain the vaccine effectiveness. You explained it better than I.
Okay, yeah, no problem, no problem. So vaccine effectiveness has been on everyone's mind for quite some time. And what I would like everyone to take home here is, what is vaccine effectiveness initially based on? Well, when we heard those numbers, particularly so maybe let's just back up. She went over J&J, right, where we actually had to use an adenovirus model to teach ourselves about how to make the spike protein, or make a spike protein-like protein, so that we can then begin an antibody response. Then we have the mRNA based vaccine tech that came out, and that's your Pfizer and Moderna, which are very equivalent. So as you can see with Pfizer and Moderna, in the high 90s with the original strain, they did great. Not as large amount of data at that time. I think it was about 45,000 for Moderna, about 30,000 were used there to develop the original vaccines. But the thing is, the variants are coming out so quickly, they're not going back to the drawing board each time to try and adapt it to another variant. So we have to kind of have some time, people get infected, those that actually have the vaccine, trying to see how well it works. So we can see here with, once again, B117, that's our alpha, okay? Our B1351, that was in South Africa, often sometimes referred to as mu. And then we have our P1, that's the Brazilian strain, and then B1617, and that's our Delta. And so we can see that efficacy slowly weighing down as more and more mutations occur. That's the biggest thing I want you to take out of this. But also J&J, which really I think should have been a 2-shot series. Now they're saying the second shot is a booster, which you can get within 2 months after receiving your first. But that's why we can see efficacy with the Wuhan all the way to Delta slowly went down. But remember, efficacy, we're looking at hospitalization and death, the protection from hospitalization and death, not necessarily transmissibility. How much does it reduce infection? Just like the flu vaccine, you can still get the flu, but the point is, are you able to less likely spread it to others? And does it stop you from going into the hospital and from dying? Which is a big reason why there's been such a push over the last 6 months for everyone to get vaccinated, primarily because we start trying to stop overwhelming our healthcare system. So that is the biggest take home here. Now we will start to go into Omicron and its effectiveness. So vaccine effectiveness against Omicron. What I would want people to understand here, and I know this was like a busy table, and most of our data that addresses Omicron comes from South Africa. And particularly, we're looking at the number of tests administered. So if you look at that sort of big round circle there, they were testing tons of people between September and October. That is our comparing period. That's before anyone was talking about Omicron. So that's our Delta, because that was dominant in the world at this time. Our second set from November 15th to kind of December, that's our Omicron. So we're assuming everyone there, the dominant strain at that time, as everyone started to hear right around Thanksgiving, that's Omicron. So what I want people to focus and pay attention to is when we're using, this is tested with a Pfizer vaccine, and I'm kind of saying Pfizer and Moderna as being equivalent. There's about a single % efficacy difference between the two. Some people say, I'm team Moderna, I'm 95%. Mind you, they're often referencing Wuhan data, and they'll say, well, you have that janky J&J, and you only have 72%. But we're going to talk about Pfizer and Moderna right now because they're fairly equivalent to one another. So what I want people to take away here is people that were greater than 2 weeks out after their second dose, where a test was administered, they had 706 positive test results. Well, out of those 706 people, mind you, they're vaccinated, 77 were admitted to the hospital. But if you look at people that were not vaccinated, this is just going over vaccine efficacy with Delta, you had 5,000 people, so about 10% of those folks, and quite a few more were admitted to the hospital, 684 versus 77. So we know breakthrough can occur, and breakthrough, you can still get some people that if they have other comorbidities, heart failure, hypertension, diabetes, hypertension, excuse me, I think I said that twice, you can still be at risk for hospitalization, but your death risk goes down significantly, but you're far more protected than someone that's not vaccinated. But when we get over to this period, the Omicron period, we have quite a few tests that were administered, but now you can see, look, there's not that big a difference between those that were unvaccinated that were admitted. Excuse me, it's almost twice the about 100 folks different in total of that led to a COVID admission. And then we see actually the positive results. So you can look at that and go, well, wait a minute. There's almost as many people that were unvaccinated to those that were vaccinated that had a positive result for COVID. Thing is, we can see from just comparing the two, though, it's less deadly. Less people were admitted, but more of Omicron was able to break through the vaccine, particularly so about 19% breakthrough. So it had about 1.8% breakthrough was the risk with Delta group, and it's about 20% right now. So that's why the efficacy will tend to be from studies that are coming out from the UK, the Danes. That's some of our most recent literature is coming from, particularly that closing out with their data collection around the end of December, is efficacy and protection for hospitalization will be still around 75 to 70%, but you're going to get about 20% more for breakthrough cases. That's why you're seeing so many people that are even have boosters that are getting some breakthrough. However, they tend to have very, very mild symptoms. So how transmissive is it? So this is that Danish study that I was referencing a little bit earlier. Omicron is about 2.7 to 3.5 times more infectious than Delta. As I said, about 19% of Omicron infected individuals often led to a household member getting it versus almost half that when a person that had Delta was in the same household. And fully vaccinated and boosted individuals are generally less susceptible to getting infection. So even in a real life scenario, I had 2 people. I was infected about, a little over 10 days ago. And when I was waiting for my test to come back, that means you're often infectious 2 days or a day before you're symptomatic. And then once that 2-day mark kind of occurs after you've been exposed and infected with Omicron, then you can develop your symptoms. And then during that time is when you're most likely to spread it. Well, my significant other she got infected. However, my house guest that was here with me, he tested negative by PCR, and another house guest, and they were around me sharing the same room. So not everyone was able to break through. Mind you, I didn't get the call until the second house guest of my positive result. So I did my little contact tracing, but it's so mild. And I'll even share, my only symptom was just clearing my throat. That's the only reason I went and got tested, because I was like, I haven't had to clear my throat lately. And lo and behold, that was my Omicron symptom. That's how mild it was. But I still was boosted. I was part of that 19% that broke through from a house guest. So why is Omicron more transmissible? Well, so it's part of it is the antibodies are more difficult for them to bind to it, to stop it from going into the cell, that the vaccine has taught our body how to make. antibodies to that spike protein. Well, because it has so many variation, it's hard for it to have that special tight fit around it to block it from entering into our cell, or to stick onto it to then tell our T cells to attack it. It's very difficult for it to do that. It also is so evasive that all those monoclonal antibodies, your Beliximab, your Regeneron, the vast majority of those do not work at all. Too bad I can't show the one slide, but if people were getting infusions earlier in the year, they won't do anything with Omicron, except for about 2 or 3 agents that worked with Delta and on Omicron. But once again, does your hospital have that? Maybe they worked out a deal to have a different type of monoclonal, so they're sometimes short. And vaccination itself is not sufficient, as with prior variants of concern, but it's still very effective at preventing hospitalization and death, but it's not as effective as stopping breakthrough. So Omicron infectivity and virulence. So it infects and multiplies about 70 times faster than Delta. So everything I'm comparing here will be Delta as our baseline, not the original Wuhan strain. That's considered ancestral at this time based on how it's been replicating and how many changes have occurred. So Omicron likes to hang out in our nose. That's why more people have sniffles, sinus symptoms, and a little bit in their upper throat. It can definitely replicate and bind to our lungs. And it can infect our lungs, as you can see in this photo here. And that's kind of like the virus here with the spike protein binding to the ACE2 receptor that Ayan had mentioned earlier. But it doesn't prefer our lungs. That's why many people sometimes won't have cough. So it has also lower disease severity because Omicron replicates less efficiently, actually less efficiently than the original strain. So it can get in to our cells, and it replicates, but many of those aren't able to get out and then infect other cells. So that's why part of our immune response tends to be mild, and we don't get a lot of ICU admissions with Omicron, particularly in vaccinated individuals, because one, our body isn't able to get a strong immune response where it often releases a chemical called cytokines when you're sick long enough that your body is trying to that's when you get high fevers and people start getting clots in their limbs, all from something that can happen often in septic bacterial infections. They get a cytokine storm. Well, that's our body's immune response to the virus that actually damages us. That's one reason that's not occurring with Omicron, which is why it tends to not lead to as much hospitalization or ICU admissions that often sometimes end in death. And one of the other reasons people are on our ventilators is it likes our nose and our throat. It doesn't like our lungs as much. So would you like to go through this, Ayan? This is where we stand now.
All right. So our current CDC guidance wants us to wear the K95 or N95 mask. So let me just bring up a website really quick. All right, so until February 7th, we have a mandate to wear a mask, and the respirator ones are the best kind. So if you cannot find any at the store or you can't afford to buy one, they are giving them out at all the Salt Lake County libraries and senior centers, and I'll add the link in the chat. For testing, what's that?
Keep going. Go on.
For testing, we have the antigen, which is also known as the rapid testing, and the PCR. So just make sure you're screening, just for screening purposes, make sure you're getting tested if you've been exposed or have had symptoms, like Dr. Ferguson said. When it comes to isolation, the CDC guidelines have changed. So make sure you are isolating now for 5 days or until the test results are back. We know that testing right now has been pretty crazy, so it may take a bit longer to get your results back. Make sure you are masking, even at home if you live with others. If you have to quarantine, so quarantine means staying in when you've been exposed, and isolation is staying in when you've tested positive. So 5 days as well, whether you're asymptomatic or symptomatic. And then for 5 days after that, you still want to wear your mask. In terms of returning to work, testing for that is no longer required. It is optional, and there are rapid antigen testing for that. So,
Very good. So what I would like to kind of advise people here is, and Ayan will go over a bit more on where to go and get the K95 and N95 masks. That's something that Salt Lake County has put out recently, and they're wanting as many of the Salt Lake County residents and citizens to be able to comply with that. It will reduce the ability to transmit. Pretty much that 95 is 5% of whatever you're breathing or would inhale as a chance of making it through. You kind of have this electrostatic effect with what the K95 and N95s are made out of that stop the virus from getting in, but also the material it's made of is a respirator that filters 95% of anything that would kind of get through. So it's what we use in the hospital. It's what allows me to work in the emergency room and come back and not spread COVID to anyone here when I'm flying, but also none of the inpatients can infect me. And it's been fairly good, and it's done me well for, almost 2 years now. But the other thing that I'm sure is going to come up in questions is, when do I get an antigen versus a PCR test? And what I want to say is, antigen is good for screening if you've been exposed to someone and you become symptomatic. And particularly if it's a sniffle, clearing of your throat, headache that seemed to come out of the blue, a cold-like symptom. But the thing is, PCR is far more sensitive, but antigens are specific. The antigen rapid tests are specific. So that's why sometimes they really aren't very good until you've been sick for 2 or 3 days, as opposed to a PCR test, because of its high sensitivity. And believe me, people know when they go way up your nose, they're like, wow, they must be getting the good stuff up there. You will tend to get a result, hopefully in 2 to 3 hours, but some, it takes longer than the rapid. And that's why ideally PCR is the best if you're trying to detect early. If you're symptomatic, antigen is usually pretty good. If you have a positive antigen test, they have a very low false positive rate. They are more likely to give a false negative if you take it too soon. So you don't need to then get a confirmatory PCR test for the 2 main rapid antigens that are out on the market. It's unnecessary. It's not going to end up inadvertently reporting a false positive. And of course, returning to work, while some people are requiring tests, why some companies are not, biggest thing to take home here is a PCR test can still be positive 3 weeks, sometimes a month or more after you've been infected. So we can't have people out of work that long. So that's just because it detected some old RNA, COVID DNA RNA up in the nose. Instead, it's better sometimes for an antigen test, because that, if you're going to use a test to return to work, is better at detecting acute or active infection. PCR will just tell you if you have that stuff still in your nose or not. So it's not as good. It's less likely to become negative as fast as the rapid antigen. And I'm going to allow time for questions and answers here, but what I kind of want to review here briefly is pandemic versus endemic diseases and infections. So as we can see here, a pandemic, it's an epidemic that spreads over multiple countries and the continents. That's SARS-CoV-2. Also, flu of 1918, as we can see on the top right. That's everyone that was in these large field hospitals in New York that they did out of schools and auditoriums, because there was just so many thousands of people getting sick at once. But then also we have an epidemic. So that's a disease that affects a large number of people in a community or population. So that's often country specific. And one notable that I will give an example is the opioid epidemic. I'm sure many people probably don't hear about the opioid epidemic affecting China, Indonesia, Rwanda, Cameroon, Japan. I could go on and on with the number of countries, but given the lawsuits that are going on, pharmaceutical industry 90% of these narcotics are having their damaging effect in the US. So it's an epidemic in the US primarily when it comes to opioids. And that's very unfortunate. Glad we're doing things to address it. But that's an example of an epidemic. So remember, pandemic, the world around. But when something becomes an endemic disease, it's kind of there in the background and has a constant presence. An example of that, sub-Saharan Africa, you have malaria. So Nigeria, Congo, malaria is kind of there all the time. That's why many people say, all right, I'm getting ready to go to Lagos. Let me start my doxy now. Or it's more the rainy season. Let me get ready. But it's there all the time. It's not just there when it rains. Kind of, and try to think of the closest correlate here of this young man, chickenpox. I'm sure some people might be on this call that remember chickenpox parties. It tend to spread a lot at the beginning of the school year. You get it once, comes back later when you're over 55 as shingles. But you get chickenpox, people didn't think so that was too bad. It often led to a lot of time from parents needing to take time off of work, kind of now, if you have an unvaccinated child over 5 with COVID. You probably wouldn't need to take as much time off from work to be with your child if they were vaccinated. But it's a decision you have to make with, of course, doing what's best for your child, but also what's best when you discuss their risks with their physician or pediatrician. But what I want to get at here is chickenpox is still around, and people were very slow to actually adopt the chickenpox vaccine. I think it's well over 89% adoption right now throughout our nation. But when it came out, I want to say 94, 95, it was low. People weren't really quick to adopt it because it was mild. It wasn't very virulent. Didn't lead to kids really getting hospitalized. Kind of how Omicron is right now. Kind of what Delta might, or excuse me, not Delta, what COVID might eventually develop into, being a background, year-round, cold-like virus that we may eventually start to take for granted, like chickenpox, if we are vaccinated. So what I want to take home here is this, I strongly feel, based on talking to professionals and experts in the field, this is where we're headed, an endemic world where we live with COVID, just like we live with chickenpox. All right, would you like to go through this, Ayan? I know you kind of went through this a little bit before. Actually, this is kind of a repeat from that one slide. We'll just skip through that. All right, this is your show.
Perfect. Yeah. So like I said earlier, the Salt Lake County is offering free respirators, also known as the K95 masks, at all Salt Lake County libraries, as well as senior centers, And I'll add the link in the chat. And you don't have to give them an ID or anything. You can just show up during their office hours and pick up a mask for you and your family.
Take a screenshot, everybody. Snap it with your phone. This is important to know. This is the better protection until somebody figures out if we need another dose or another shot, because sometimes these masks are not cheap. I can tell you that.
So the links will give you more detailed information on where all of these locations are. And then we can move on next to the testing sites for anybody who wants to get tested. Yes, thank you. Perfect. So these are just 3 state-sponsored free testing sites. There are other ones, but these are the main ones that people go to: the Utah State Fair Park. Ours are right there, Maverick Center, and the Cannon Building. They're all drive-through. But with the Cannon Building, you are gonna make an appointment. And I believe Fair Park and Maverick are asking to have you guys do appointments for now, just because of how busy it is. But the Cannon Building requires appointments. And then I will also add in the links for the website, the coronavirus.utah.gov testing location website. You can enter in what city you live in, whether you want like a saliva PCR or the nasopharyngeal PCR or the rapid. You can check to see if it's free or not. University of Utah offers them Intermountain does as well, Know Me Help. But this is just a few of those that are state sponsored. And then to register online before you head out to these testing locations, you want to go to testutah.com for that, okay? That's about it.
All right, and these are our references. I'm very happy to share this presentation with anyone afterwards. And now the good part. So now I can stop with screen share. Let me find over. Here we go. Now you can look at me dead on.
Thank you for that presentation, Dr. Ferguson and Ayan. So we have a lot of questions in the chat, and I'm gonna start reading them off in no particular order. Gifty is gonna help me at some point. So the first question that we have is, let's see.